Good afternoon, everyone. My name is Dr. Macy Levan. Welcome to the Behind the Paper podcast for the Transplantation Journal. Today, we're talking about clarifying the donation after circulatory death process, addressing misunderstandings, correcting misinformation, and building trust through education. I'm joined by three authors of this perspective: Gabriel Gondolesi, Marty Manalkic, and Steve Potter. They are here to talk with us about all things DCD. Thank you all for joining us. Would you all go around and introduce yourselves and tell us where you are from and what you do there? If I could start with Marty, that'd be great.
Okay, my name is Martin Magnalik. I'm an anesthesiologist, president of the DTI Foundation, and professor of Barcelona University.
Steve
Hi, I'm a professor of surgery and abdominal transplant surgeon at Georgetown University Hospital here in Washington, D.C.
and Gabriel.
How are you? I'm Gabriel Gondolesi. I'm a transplant surgeon, director of pediatric liver transplantation, and associate director of intestinal transplant at Georgetown University. I'm currently president-elect of the TTS, and when we wrote the manuscript, I was the vice president of the TTS.
Fantastic. So let me start with you, Dr. Gondolesi. What prompted your team to write this perspective now, and what misunderstandings about DCD did you want to address the most?
I came from a country, Argentina, who suffered for many years that when the press released news against donation, and we're talking about DBD, there was a very significant impact on the willingness to donate from the general population. We always call that the yellow press impact negatively on the rate of donation. And in countries like ours, the impact was very significant, reducing the number of the DVD donors for more than 50%. That impact has been proven, and there are literature that supports that fact. And certainly, I moved to the United States in 2024 and was very impressed by news that came out in Washington Post and New York Times about DCDs. And really, I started to talk to my colleagues. Some of them were the co-author of this manuscript, saying we clearly need to step up and clarify the issues that are brought by the news, because after experience significant impact on the donation rates, I don't want this practice to be mistrust, and I don't want this practice to be bad judged by the lame people. And if we don't do it right away, then you will have a long-term impact and will be very, very negative in the volume of donors that our country, in this case, United States, will have. Therefore, this was what made me start thinking about that, and I contacted immediately Dr. Mañanich, who works in a country, and we'll talk a little bit more about other issues like the impact on religion, etc. But coming from a Catholic country where they developed DCD for 40 years ago, and how they practice was very successful. And I think that always you have to learn from the people that develop the practice, and also how do you put this practice in place. And like
Yeah.
I said, I came from a country where DVD was questioned by many physicians. Was very hard for us to establish the DCD practice when you don't have a clear DVD practice. Therefore, Marty has helped us a lot, and we were successful to evolve DCD. And now in United States, I want to be sure that we can practice under ethical regulations, both DCD and DCD, in order that the general lay people can trust our system.
Yeah, that's a lot of good points there. Let me back up for a minute. And I want to go to Steve because you guys talk about a media, narratives and cases in this paper. But Steve, do you want to kind of bring us back to why this started in the United States and talk to me a little bit about the actual stories that were put out there in the media and what that meant?
Yeah, I mean, I think Dr. Gondolisi made a really great argument for a simple point, which is that we're completely reliant in order to do transplantation on the public trust. And the public trust specifically in terms of their willingness to make that precious gift of life, which is such a sacred thing. And so what we've seen is a potential erosion of that public trust. And I think one of the drivers of that is that some stories have kind of bubbled to the surface in the media, raising concerns about donation after circulatory death. And so that's one of the primary drivers of why we think that it's important to get the word out and why we wrote this manuscript.
Yeah, because DCD is not unsafe. In fact, right? Like, how should clinicians understand those cases in the context of established protocols?
Yeah, so DCD not only is it safe, I mean it's saving lives every day in this country. DCD has become the way that the majority of deceased donor livers are obtained, and it's headed towards a majority on the kidney front. In fact, we've seen that donation after brain death donation is really flat or declining in this country for kidney and for other organs as well. So this is critically important. It's a standard of care. It's absolutely safe, and it's a standard of practice.
Yeah, absolutely. Um, can you explain the mandatory no touch period before we kind of move on to some of the more details?
Yeah, Macy, that's a great question. The mandatory no touch period is a point. It's an absolute must-have item, and it's also something that as I explored it in my role as vice chair of the OPTN Operation Safety Committee, development of DCD protocols to be promulgated to the community, we found this was an area of major practice variation. So the majority of hospitals in the United States and the majority of OPOs use a 5-minute no touch rule, but there are some places that use a longer and some that use a shorter no touch rule. And this has to be clearly stipulated. The 5-minute time is not just pulled out of thin air, it's based on the longest physiologic and observed evidence of autoresuscitation ever seen. So we know that 5 minutes is a evidence-based time and a safe time to use for donors.
So that's what people need to understand is that there are policies in place that make DCD safe for clinicians and families. And if somebody is really struggling with that, what would you point them to? This policy you're talking about that you developed, can you tell me more about that?
I would like to give the word to Marty because the 5 minutes is not only about the policy, it's about the physiological time where you also are or evolve brain death. And I think
Perfect.
that's what I want Marty to expand more because he's an expert on that. He has published on this and should be the person that will clarify this issue.
Please.
Yes, no, I'm an anesthesiologist and resuscitation expert. And then we know that after one brain with less than 3 minutes of perfusion, it's death. 5 minutes give the guarantee that after 5 minutes, no perfusion in the brain is reversible. Not for donation, no, for the person to declare death. And that is what happened in the current practice in the emergency area, in the ICU, or what on. Then for the DCD, they have implemented this no touch period of 5 minutes, and I think is absolutely safe. Also, my colleagues in Murcia and Santander have made a study. Also, they have checked if there is any kind of perfusion after the 5 minutes with a gamma camera, no, a mobile, and there is no perfusion of the brain in any of the cases that they put in the study, and also is published recently.
So, more on that point, you describe in the paper sort of the value of uniform withdrawal practices, regardless of donation is being considered. Why is consistency so critical?
That is important because when we talk about DCD, that is the consequence of to implement a protocol of withdrawal the sustaining life treatments in the patients in the ICU. that in Spain was not a common practice in the 2000. So to start DCD, we take 12 years from 2000 to 2012 to all the ethical committees in the hospitals to implement protocols of the without treatment to all the patients. Then the consequence is the ones who are the criteria for donate and the family accept that become DCD. And for that is very important that no that is a hospital practice. The difference probably between US with the donation is more managed by the organ procurement organization who covers the territory. In Spain is more a hospital organ donation unit. We have 188 hospitals, and in each hospital, the TPM coordinator, the profile, 70% are from the ICU. So this is a clinical it's a clinical care of the patient. No? In the morning when the physicians in the session say, okay, a patient from whatever is futile to care. It's not one doctor who assigned as a potential donor. It's assigned that is a futile to care. And then they inform the family, and that's it. No? It's a consequence of the care in the ICU. And I think it's a good practice, no, to introduce worldwide that the disease donation is part of the care of the end of life. And that is what we did. We have been training people worldwide, but in the 2000 we start to talk about DCD in France. It was not DCD. Now they are doing. They have been training also in Italy. Also they have in Portugal, etc. No? And all the Anglo-Saxon countries, as you in US, people from UK also came here, people from Sweden, etc. But his regulation don't allow to practice as we do. So for us, it's the ICU practice. Even the cannulation after 5 minute not periods, many times is done from the ICU by the cell inject technique that they do in many other patients. They do the ECMO, extracorporeal mechanical oxygenator, they place the cannulas. No? But in UK and in Sweden and in the States as well, it's not allowed to cannulate pre-mortem. They have to be, in Spain, our law since the year 2000 allowed to do two very important things for the outcome of this organ. One is to put heparin to this body, and second is to cannulate pre-mortem. And just to finish this, and the family in the ICU know the procedure, stay with the relative as long as they want, and with the time to leave, then we can move the body to the OR for the process of the retrievals. Yes, no, for refusals, it's only 10-15% of the cases as a DBD. Even it's less because for the DBD, families have to stand brain death, no, it's too worse, and the heart is beating and the thorax is breathing. No? But when you talk about cardiac death, no, people understand very, very quick.
That's interesting. Dr. Gondolesi, because the paper responds directly to these media narratives, in your view, how have those narratives blurred the differences between what Marty was saying with brain death, circulatory death, and irreversible coma?
It's very interesting because, and we put in the manuscript, if we don't lead to educate people at all the different levels in one precise protocolized way, the system will fail. Therefore, in the past, when DVD came to place, and Marty and Steve can support that, many times we go into with the donors and the donor has some reflexes in the operating room, and many times the nurses in the OR call as a patient advocate to stop the process, and we have to reassess the donor to be sure everybody's confident that this was a reflex and not a sign of life. And once brain death was proved again, we were able to proceed with donation. Now, it's very important to understand that the practice of DVD has been, with us for more than 30 years or 40 years. Now, DCD is slowly evolving. We published 26 countries from the 187 that respond to the organ donation and transplantation database from the WHO practice DCD. only 26. Therefore, if we want to expand to all the countries, we need to do it in an homogeneous and ethically appropriate way. Also, I've been, saying that there are two different ways of dying, brain death and DCD. The reality is that at an ethical point of view, you die when your brain function is exhausted. And that happens when you have brain death or 5 minutes after you are in a no touch period on a DCD. And this is very important because comes as a question from many of the ethical experts about declaration of death. And I think that that's why we had to have a clear understanding of the whole process. And also, we are responsible to understand that DVD or DCD are not interchangeable, are two different pathways. If you are declared DVD, you need to continue on the pathway of the DVD donation because the organs are going to have a good quality. And as Steve was saying, when you are grieving and your family accept donation, the more organs that your donor will give to the people, the better you feel as a family that wants to donate.
Mm-hmm.
And I think that this is very important. That's why, as we mentioned as well, today, to have similar results with DVD, the DCD has or is being attached to the NRP practice. And this is other aspect that we will discuss probably in this podcast later, but they go together to have similar results. But one part is DVD and the other part is DCD.
Two different pathways for donation. Both have distinct protocols in place to ensure safety, ethics, public trust, and family understanding.
Yes.
Dr. Potter, the article stresses some strict separation between the team caring for the patient and the organ procurement team, which is, I think, and I hope, part of the standard pathways for no matter what type of donation this is, right, in any country. How does that separation work in practice, and why does it matter?
Well, let's start with the last question. It matters because it's an ethical requirement that there's no connection between the folks who are procuring organs or placing organs with the folks who are caring for that family's loved one. And in fact, for as you mentioned, Macy, for any pathway leading to donation, that's an inviolable rule. It's followed uniformly in every site in the United States without fail. And we wouldn't have it any other way.
And so, what do ICU teams and transplant professionals need in terms of training to support like communication confidently and accurately with families, particularly in the context of DCD?
Yeah, the organ procurement folks have done a really good job of educating hospital personnel, including attending physicians, and focusing mostly on the ICU. And so that's been very good. But I think there is potentially an unmet need, Macy, in terms of HRSA Department of Transplant and the Organ Procurement and Transplantation Network providing overarching educational materials and, very importantly, DCD protocols that can help standardize everything universally across all the hospitals in the United States. I think that the OPOs would welcome that, and I know that donor families would welcome that.
Yeah, I personally have some concerns about saying that that should be something that the government should do. I don't know if they even know how to do that, but that could be a conversation for a later time. Like how would you envision the government creating those types of protocols? How do they know what needs to be done? Isn't it the people that are on the ground doing the work that know?
Yeah, but that's the beauty of it. The government wouldn't develop those. Those would be developed by the OPTN, which is not the government. The OPTN is a public-private partnership that is essentially our community, all the stakeholders with the expertise coming together to make those guidelines. The role of the government is just to promulgate, to give an imprimatur to those guidelines and get those disseminated.
Also, if I may, in many countries, the organ procurement organization, you can name in different ways, they usually are supported by the scientific societies like TTS, ASTS, ASTP, etc., that have the people that know. You sometimes in life you don't need to know anything. You have to have the phone of the people that knows the most
Right.
and ask them to guide you and take their advice to put them in practice. But you can't work in a silo. You have to work with the community of experts that work on that. And going back to your previous question, I do believe that Marty can also comment on the way that Spain is approach the families, which is extremely important because it happened not in every country, where the role of the ICU is key on that, because the patient has been taken care for, let's say, certain period of time, days, weeks, months, by the group of physicians that the family know and trust. That's why, Marty, please, if you can comment how you work in your
Mm.
country.
No, I think for the question of Macy, how is the trust of the population, no, in Spain? And I go to your answer, no, Gabriel, because fortunately in Europe is more, you have a national health service. It's a universal coverture of all the people, and people more or less are happy to have this service, no? Second, what happened in donation and transplantation? We started a national program in 1990. I started in 1986, a little earlier. And today, so the patients in the waiting list for a transplantation, the time is less than 1 year. So less than 1 year, you can have a heart along, and that means that all the population have a neighbor, a relative, a friend who have been transplanted. And the media helps us a lot because media usually don't criticize, because the National Transplant Organization, ONT, used to give news about today have been 25 transplants in 1 day, the more a small child, whatever, and that becomes that the population have a trust in this, no? Go to the question of Gabriel, no? I tell you, in 2000, with Dr. Matesans, we said, okay, Marty, DVD is optimized, now we can go for the DCD. Wow, be careful. Because countries who start DCD, they decrease the DVD, make like the switch. The ICU don't continue the care until brain death is established, no? But in this way, the Spanish government spend all the money in educating the health professionals. And then they make a link with a Spanish Society of Intensive Care, a Spanish Society of Anesthesia, a Spanish Society of Emergency, a Spanish Society of Neurologists. What it means, any fellow who will become specialized after 5 years in my country have received 3 days training about organ donation, DBD, DCD, so they are familiar, one. Second, they go to one hospital. Oh, there is a protocol for the end of care of life. You have to refer any potential donor, DBD or DCD. Oh, there is a potential DCD. Okay, pues then we discuss in the morning what are the candidates, no? And that is the main limitation in the world to have donors. So here have two excellent surgeons, but how many anesthesiologists in the world are familiar with that? We have only 10% of the global need of organs, not because we have no surgeons or we don't have enough patients in waiting list, no, because 90% of the specialized in the rest of the world, they are not trained, educated, motivated, or that at the end of the care of life include organ donation. No? And I think this is something that in the future, and here TTS or whatever can help to develop that. To do a transplant, I need a nephrologist or have a patient. I need a surgeon or Potter, but I need an ICU doctor to find the donors. If there is not three things, donation never can be growing and growing, no?
So we're saying more education and more involvement in the ICU clinicians.
Absolutely, absolutely.
Yeah.
That is the key point. So the success of Spain is not by the structure, it's not by the law, whatever. It's regulated, but we have 188 hospitals with ICUs, and all them have a team of TPM, I call Transplant Procurement Management Coordinators, in charge of that. No? And that is the common practice, and well, since 1990. 600 people for a country of 50 million. That is 12 TPM managers per million of inhabitants. Then if you want to be 50 donors per million, then you have to be 12 TPM in the hospital. And when talking about the DCD, that the mix of donors have changed. No? Now I tell you before recording that in Barcelona today, 72% of our donors are DCD. Never any misunderstanding, no problem, whatever, no? And in Spain, it's like 50%. And the good news, and I think Gabriel also mentioned, that is the number of organs obtained is the same that DBD, and that includes heart, lungs, intestine, and the outcome also is the same. We don't discriminate the recipient who will receive from DBD or DCD. No, it's a good organ for transplantation, and that is so nice, so nice. And let me tell us something new. I have to use the opportunity. No, we started in 1986 doing uncontrolled. Uncontrolled is a little more difficult to practice, but a donor from the street, a patient who suffered ischemic cardiopathy, tried to be resuscitated, but finally arrived at the hospital and death is declared. After death declaration, we start an NRP, a normative perfusion to cannulate to these bodies. And also we can obtain like 5% of all the cardiac death in a territory can be a donor. And that, if in states, is not possible because the regulation don't allow to cannulate pre-mortem and so on. There was some guys in New York many years ago who tried, but they couldn't. So that will represent for US 17,000 potential donors because you have 340 cardiac arrests outside of the hospital or the office, no? But the regulation is the limitation. The same in UK, the same in Sweden or in many parts. So the donation for the DCD should be regulated. For example, now I'm happy that we are training Croatia for more than 10 years. Croatia have been number one in the world only with DBD, but wants to do DCD. It takes 10 years to have the law, and finally the law is approved in Croatia. Portugal is doing uncontrolled because it's a normal consequence. Emergency department, dead bodies arrive, death is declared, they ask to the family and they do the procedure. And finally, after 20 years doing uncontrolled, now they will do control because the law had been approved. No? So the limitation, for my point of view, for the donation is to have a good regulation, but also at the hospital level, in the emergency area and the ICU, all this kind of the clinical practice, not only the doctors and the nurses and everyone have to understand that the care of the patient don't finish with declaring death. The care of the patient finish first to refer the donor to the organ donation unit, and second to establish the procedure. While DBD, we know the examine of brain death, or why DCD, how to implement the will drop treatment. No?
Steve, does that work? Would that work here in the United States?
Would uncontrolled DCD work here in the United States?
Just as a general thought. I mean, I know there've been experiments. I know that's been part of our history and innovation and trying to innovate, but
It's a great question, Macy. I think it would in select circumstances. I think it's gonna, I don't think that's going to become a huge source of usable transplantable organs, but I think that it's a source of organs that are potentially transplantable and it should be explored.
yeah. So our focus should probably in the United States be on, what are the most important components of a DCD process that will build and maintain public trust in our transplant system. And from your perspective, Steve, what do you think those are right now? What do we need to be doing today?
I at the OPTN, we actually wrote DCD guidance that I think is very good. It's very evidence-based, and it's aligned with the American Society of Transplant Surgeon uh, published guidance on DCD. And that was requested by HRSA, and then we completed that work, and it was sort of buried. It has never been released. As HRSA kind of moved on to other things and doesn't have the bandwidth to do everything at once. And I think we need to call on HRSA to get that out because that is a way to promulgate universal standards. It's a way to rebuild public trust, and it's a way to promote donation. And I think we have to work on making sure that we don't have that erosion of public trust, because it's one thing to try to add incremental volume, but it's quite another if we start to lose people off donor registries and we lose that willingness to make that precious gift to life. That would be a tragedy for all the candidates on the waiting list and for the entire transplant community.
Yeah, for sure. I'm surprised that is not out. You're right. We need to get that guidance out to the public. They deserve that. Dr. Gondolezzi?
Yeah, I want to add a couple of things. and what has been said and built. One, regarding the regulations, we should not forget to include in the regulation pediatric donors, because this is key. When you look at the DVDs around a year, the lower number of donors are pediatrics. DCD will expand the pediatric approach, but you need to be sure that the regulation include the possibility of using DCD NRP on pediatrics. And we're talking about pediatric, I'm not talking about the 17-year-old pediatric, I'm talking about the young kids that are younger than 1 year of age. And in many centers, the ethics committee approve abdominal NRP, but do not approve thoracoabdominal NRP, which is a concern and a problem, because in such small kids, you need to cannulate them in the heart or directly in the chest, because the size of the cannulas are not appropriate for that size. That's why it's very important to don't forget about the pediatric patients, about in the regulations when they come out to be used. The second comment I want to make is when we talk about do not have mistrust, I'm going to build on what Marty was saying. If we want to have a society that donates, we have to start the culture of donation in the kindergarten, in the primary school, in the high school, in the school of medicine. This is cheap. But if you look different countries, I'm going to talk about my one, we have more than 120 medical schools. Only 5 have a subject on donation and transplantation. You talk about donation in surgery, you talk about transplant in immunology, but there is not a dedicated subject for donation and transplantation. 5 over 120. Therefore, we are having people that graduate from the medical schools in many countries without never hearing the word donor. And that's something that we need to educate from the medical school, like Marty was saying, then in the residency from ICU, anesthesia, cardiology, internal medicine, surgery. And then you expand on the fellowships, and then you train the people. Many of the people that is doing today ICU care might be potential OPO leaders, but they need to know about that, and they need to know about the field. They need to know how to approach families, how to ask for donation, and understand what DVD is, what are the regulations, and what DCD is, and what are the regulations to have a successful practice.
Let me tell about this, no, because I think it's very important. So we were lucky to start in 86, the uncontrolled. Second, in the 2000, we published the first articles in the world about the NRP. And later we start doing a training for surgeons, for ICU doctors, for fusionists involved, no, in control and control. What we have to set up, that what is exactly the practice of DCD is the 4 components, and we train all the same. So Dr. Gondolesi have been with us in A Coruña last year. Dr. Steve Potter will visit us in October. And for me, it's very important because to share how it's practiced in another part is important. And I repeat, first is the ICU should be oriented to identify all potentials and to make the will draw, so that all the futile patients, and to do the will draw to all in the same way, become a donor or become a donor. Then is the approach of the family, because the circumstances are different. The patient is still alive, and you ask them for donation. You don't ask donation after death, but you know that they will die. And the third point is how to care this will drought. Patients don't suffer about that, and that is a different practice in some countries, which allowed in France, in Belgium, in Italy, in Spain. We can give sedation and analgesia. So the patient at the time of withdrawal, for donation or no, don't have to suffer. What is the consequence of that? That all this time agonal period that we call after the 5 minutes non-touch period until you can start the retrieval for us is in average 19, 20 minutes, no more. And no one of these patients never goes back to the ICU because they don't die in the right time. Fourth point is the recovery. Have been discussed our techniques in all the world, Why you do the NRP? You do the super rapid recovery. It's easier and quicker because more is in the hand of the surgeon. This practice, I still do in UK. I still do in Sweden. No, but if you do the normothermic regional perfusion, you have a full body perfused with blood, 37 degrees, and you can also monitorize the organs inside. There is not a hurry that used to happen when you do the super rapid recovery. And finally, today, and this is the 5 point that we teach, is also about the ex situ machine perfusion, when to use these machines. For us, are too expensive. We cannot spend a machine who costs, let's say, hundreds of or hundred thousand of dollars. With a normothermic machine perfusion, we have the whole homeostasis of the body, and we can monitorize the function of the heart, of the liver, of the other organs, and that is what we are teach for many years worldwide, no? In many countries, pues have started a program thanks to that. But if there is not an ICU anesthesiologist emergency doctor convinced to implement in his unit and to have the ethical committee approval, then it's very difficult to go on. No? And then the trust of the family, I think, came also by the practice of us. No? And the support of the media. Media have to disseminate this good practice. That is so for the New York Times article is to disseminate, oh, the good practice now in the Georgetown University is that they approve a protocol, all the ICU doctors are trained, blah, 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 blah. Example, sorry, because both of you are for the Georgetown. And an example just to finish, for example, in Argentina, no? I know Dr. Gondolesi, he was a student of medicine in 1993 in La Plata, no? And we start to show how to develop disease donation with INCUCAI, with a national agency. But 10 years ago, a guy from Temuco, from the north of Argentina, had been in our hospital, and he learned about the uncontrolled, and he started the uncontrolled disease donation in Argentina. You will say, why? Why uncontrolled and not controlled? So in our countries at this time, it was more easier uncontrolled because it's already a dead body. And the practice or the withdrawal of the life-sustaining treatment is more difficult for the families to understand. And later on, was this guy also implement the NRP and is the first NRP in the country. So it's a practice can be shared, can be learned, no? And we use the lecture, the simulations, the animal lab, and the clinical cases, and it's not long, no? And for the international community, because of one of your questions, no, was we can collaborate, no, with TTS, with anyone.
And also, this is a moving target because many countries that, like we're discussing before, did not allow in a donor or on a patient that has been approved to withdraw life support and which family wants to donate. To understand, once there is a consent signed for withdrawal support, we have to care about the organs. We have to be sure that the organs have of a high quality organs to help the other patients, that this family who knows the will of the patients wants to do the best, which is help more patients. And that's why in different countries that first did not approve to do some treatment on a patient who has been signed to withdraw life support, then move towards the possibility of doing, like Marty was saying, heparinize this person, be able to put cannulas to save time when you go to the operating room, because that will optimize the quality of the organs, and be able to do that in adults and children.
So donor management protocols are incredibly important. Standardization to those is critical not only for the care of the donor, the integrity of the process, the family's consideration in this space, but also for the outcomes related to those organs in the patient that they are transplanted into. Am I hearing that correctly?
Yes.
Excellent. Are there specialized places that do this outside of in Spain or anywhere else? Are there specialized donor care units? I know we have some in the United States that are some attached to organ procurement organizations, some are attached at our hospitals. So at my hospital, NYU Langone Health, we have an we have an adult donor care unit. We do not yet have a pediatric one, which I think would be an ideal situation to kind of develop. Do you know any specialized pediatric spaces?
In Spain, we have, because become common to do the NRP and cannulation, but we don't need to be the expert in all 188 hospitals doing that, no? Because maybe it happens once a year or, or twice, no? And then we have a mobile team. So, for example, us in Barcelona, we can fly to Mallorca and we can do the procedure there for the people who wish to donate. But talking to the pediatric, that is the question with Gabriel. Also in Madrid, in La Paz clinic, we have a specific team who is mobile for all Spain for any pediatric case, because for pediatric, not all the hospitals we are ready, because we need a specific material, experience, but a potential donor, can wait for the team to arrive, no? Because these bodies are ventilated, whatever. And that is can be organized. It can be organized at the mobile team in the area. We have a regional for the adults NRP, but also we have this team for pediatric as well. And that guarantee the good quality of the practice and the quality of the organs and the transplantation.
United States is a big country, and when we started to practice DCD for pediatric in our hospital, we currently have all the pediatric patients listed for DBD and DCD with NRP for liver and bowels. And like I said, we have offers from many different states. And I have been probably lucky enough that when a donor comes, and if the hospital didn't have the possibility to provide, there are other providers that can fly or go to that place to do for us the cannulation. There are cardiac surgeons, as well as placing the pump for the NRP on the PEDS patients. And we started by doing a very young 7-kilo patient for a combined liver pancreas. Then we did a smaller one for liver, and we're going to have now a publication as a letter to the editor saying that the size is not what should limit the use of DCD donors with NRP. I think that we had to move forward to try to increase the donation in pediatrics independently of the donor size.
Macy, one of the places we can have a big influence is, and where there's an unmet need, is there's a real dissonance in the United States between adoption of thoracoabdominal NRP and abdominal NRP alone. And they're viewed by many as sort of separate things in terms of their ethical implications, which is really an inaccurate way to look at it. We know that TA-NRP and abdominal NRP are both ethical and safe, and TA-NRP can provide more high quality organs, and we need to expand the utilization of TA-NRP, and we need to get synced between, so that every hospital that has deceased donors can offer both abdominal or thoracoabdominal NRP as clinically appropriate.
As Steve says, why I'm going to use a liver or kidney in one donor and miss the heart or the lungs, when today it has been proved that donors with organs procured after DCD NRP had equal or better results than DBD. And that's why we need to really increase that practice in the United States and in the world.
And we have some families that are unable to have their loved ones make that precious gift of life, because it's important for our audience to understand that in small pediatric donors, they often don't have adequate vessel length to be suitable for abdominal only NRP. They need thoracoabdominal NRP as an option. So we're losing high quality organs because of that dissonance between adoption of abdominal NRP and thoracoabdominal NRP.
And I think that one probably last comment we finished our paper saying that's clearly that the miracle of organ donation must be handled with care. And this is exactly what we're talking today, which is to increase this practice ethically. And I think that the media should help us on that, because In the same way that probably negative news sells well, good news sells more and will increase the number of donors and increase education in the general population. And I think that I have not seen really, this attitude, and we really would like to promote that.
Fantastic. So I'm going to ask you each one last question before we wrap up. If the listeners could take away one message from you about DCD, what would that be? Let's start with Marty.
Yeah, just tell me that DCD is not new. The first donation for transplantation 60s, the first liver kidney was from DCD donors, and there was another controversy, no? But now is a new practice in the hospital, not only in the States, in the world, that people have to learn that this new clinical practice you have to learn from other center or whatever. Like it's very basic for the trust in the practice in the population and to have good organs to educate mainly people who work with the critical care because they are the key person to bring the best donors for the surgeons and for the patients.
DCD is not new. Point one.
Yes,
Dr.
it's a new
Gondolesi.
practice. It's 2 decades. We restarted again, or 3 decades.
I think that DCD should be valued, care, and sustained because, like Dr. Visa from Spain also said many years ago, organs don't grow from the trees, that you can get one for your patient. And the gap between donation and patients waiting is too big. And DCD came to try to shorten that gap and help more patients. The more patients we transplant, the less patients that are on dialysis, the more life we save. That's why DCD came to stay and to grow.
Fantastic. Dr. Potter?
Yeah, I would just remind people that transplantation saves tens of thousands of lives every year. It's just in the United States alone that the United States has the largest and in many ways safest transplant system, including transplant outcomes in the world. It's the envy of many countries in the world. And all that is made possible only because of the precious gift of life made by donors and donor families. DCD is moving towards a majority of those donor organs. It's just as safe, just as protocol driven, and just as accepted and evidence based as donation after brain death. Both pathways are vitally important, and we need to do everything we can to promote them.
Absolutely. Yes. DCD is more than 50%, or just about at 50% of organ donations in this country. We just published that in JAMA from my group. So yeah, it's very exciting. Thank you all. I really appreciate your time talking about clarifying DCD, addressing misunderstandings, correcting misinformation, and building trust through education. Lots of great ideas here that we can implement not only in the United States, but around the world. And I'm sure that TTS is going to be the global leader in society, working really hard to kind of bring these ideas together for the next generation of training and education. This has been an episode of the Transplantation Behind the Paper podcast. I'm Dr. Macy Levan. Thank you to all my guests today, Dr. Potter, Dr. Gondolesi, Dr. Milianich. Thank you.
Thanks for having us.
Thank you
Thank
for the
you.
opportunity. Take care.
My pleasure, my friends.